So the supraclavicular block, this may anesthetize the shoulder, but it really depends on where you catch it. Are you getting the suprascapular nerve or not? You are going to get the axillary nerve, so you will provide some shoulder anesthesia, but you probably will need to get the suprascapular nerve separately if you want to do a supraclavicular block for a shoulder surgery. But unlike the interscalene, you'll get the whole hand. You get the ulnar, median, and radial nerves. And in case you're interested, the CPT code is 64415-76942. 76942 is the ultrasound code for ultrasound guidance. So when you're doing these blocks, I'm sure most of you are already aware of, if you're doing them, you need to capture an image of the needle next to the nerve on the ultrasound. Easier said than done, because when you're doing a block, you're not really thinking about saving the proper image. You're thinking about taking care of the patient. So sometimes you may or may not get that image with the needle next to the nerve, but at least have something that you could show the billing company or the insurance companies in case you're audited. So the subclavian artery is the most important landmark for the supraclavicular brachial plexus. The insertion of the anterior scalene into the first rib lies between the vein anteriorly and the subclavian artery posteriorly. On ultrasound, the vein is well forward of the artery and is most time hidden below the clavicle. So this is just, I call this the hybrid view, meaning it looks like it's an interscalene, yet it's sort of a supraclavicular. So I'd say it's more of a supraclavicular. However, the nerves here are lined up like interscalene. Nice, you have your ducks in a row right here. So it's kind of that transition point, I call this. So when you're doing the interscalene and supraclavicular, it's not going to look like this. This is really that mid zone between the two blocks. Or you actually may be in the interscalene region if you look at my line over here, but you're just not angling the ultrasound to see it in that fashion. This is just a cut. This is not an ultrasound image. Okay, see the nerves here? This is how they typically appear. They're not lined up like that in the supraclavicular fossa. They're just more of just a bunch of grapes. Here's the subclavian artery, hypoechoic, meaning black. Here's the first rib, hyperechoic. And here's just a little video of how I do this in the pain office. This is not how we do it in the anesthesia world because my patient is sitting up. You could do it that way, but I caution you because I'm not giving large doses of local. So I wouldn't like to give him 20 mLs of bupivacaine and have him sit up for that. I would lie him down for that. Here I'm giving about 3 or 4 mLs of dilute bupivacaine to anesthetize him for a shoulder bone marrow aspirate procedure. So this is like I'm giving regional anesthesia here. This is not really a pain block. I'm doing it for regional anesthesia because this surgical procedure is actually an injection of bone marrow aspirate into his shoulder. But I don't need large volumes here. So I'm giving him the 0.25% bupivacaine, and you could see when I'm approaching from behind like this, I'm not aiming at his lung. His lung is down here. So in my opinion, this is way safer than they're teaching you to do this in the operating room, with the exception of if, God forbid, this patient bagels and falls. But then again, we do epidurals with patients sitting up all the time. So why should this be any different? You're looking at the imaging and you're making sure you're not injecting that into a blood vessel. So it's arguable. However, it's not what people are doing. Nobody's really doing this block sitting up. No one I know is. And if I had to put a patient if a patient was going for surgery and needed 20, 30 mLs of local, even 30 is a lot in this area, maybe 15 to 20 mLs in the supraclavicular brachial plexus, I don't know if I'd sit him up like this. Maybe I wouldn't, and I'd just give it slower. But it's very easy to do it this way. And I find it to be a lot safer because you're aiming anteriorly and not at the lung. So the supraclavicular block is pretty reliable. You can usually get a comprehensive block with minimal redirects of the needle. You're avoiding, for the most part, you still can get some phrenic nerve paralysis, but it's not as much to the extent as the interscalene. The interscalene has a very high rate of phrenic nerve paralysis when giving large amounts of local. Once again, like I said, I never seen anyone complain of shortness of breath when doing an interscalene block in my office with just 2 or 3 mLs of local. So you have to be careful if the patient is suffering from COPD or has some other respiratory problem that could compromise them. For procedures of the upper arm and elbow, the block is a simple alternative to the axillary approach. Even with the ultrasound guidance, like I said, very few redirects are necessary. And once again, you're looking here, you see the nerves and the arteries over here. Here's the rib. Okay, in case you forgot how to read x-rays, this is a pneumothorax. Notice the absence of lung markings out to the side. In the pain office, I'm doing these blocks once again for patients who present with brachial neuritis, and I'm using it to anesthetize patients for other procedures. I am using dexamethasone quite a bit for my blocks to prolong the effect. From the literature I've read on it, beyond 4 milligrams is not beneficial. So I wouldn't give more than 4 milligrams for nerve blocks. And I'm using 0.25% bupivacaine. Sometimes I'm diluting it. Ropivacaine would be great. We just don't have it available in my office. So just some tips here. You can keep the lungs out of the way by just you can stay away from lungs by just basically keeping everything in plane, seeing your lungs, seeing your needle, seeing the nerve, the target, just knowing where everything is. Go slow, take your time. And once you get to the brachial plexus, inject slowly in the area. You don't want to inject too quickly, and because that can maybe increase the risk of wasting your local in the wrong spot, or maybe if you are in a blood vessel or near some open venous sinus veins or anything, just a high pressure injection could cause possibly some more damage or side effects that we just don't want to deal with. We have enough problems.